Uh, this session is very, very important in palliative care. Today we have an eminent faculty with us, Dr. Greeshma Nair. She's a political and now she did her certificate course in palliative medicine from Pallium, India, and she is having 2 years of experience in palliative care. So, ma'am, welcome and over to you.
Thank you, Sister Sheila. Good afternoon, all. So today we are going to learn about delirium. So do anyone have any idea about delirium? What is delirium? You can unmute and answer actually. What is delirium? What comes to your mind when you hear about this delirium, the word delirium? Do you have any idea now? You can answer in the chat also. Yes. I think Sister Prince has sent us a message like mental status. Yes, it's related to something related to mind. So, what will happen to the mind? Okay.
If you are not able to speak, please type it in the chat box so that everybody can see it.
Yes. Confused. Yes. Clouding. Cloudiness of the thought. Yes. Yes. Yeah. It's true. It's something.
नमस्ते बढ़िया आप बताओ
Yes. Next. Today we will see the delirium in detail. As you have mentioned, it is like something, it's a confused state of mind. So the term delirium, it's derived from the Latin word delirate, which means to go out of the furrow or off the track.
पैदल बहुत चलना पड़ा था
It's,
घर से उतरो अब दिक्कत हाँ अब यहाँ का
Ankita,
सामने है
Ankita,
okay. What you did you get any information from this picture that is being shown here? Somebody is very agitated, right? So everyone is trying to restrain him. You can see this, right? So you have to keep this in the mind, this picture. Okay, next. Okay, why we have to learn about delirium? Okay, I want to ask you one thing. Did anyone treat delirium or confront delirium in your OP or IP settings before? The real cases. If uh, if you saw this before, you can answer in the chat also. Yes. If you people didn't see delirium, then I have to describe that. So that is why I'm asking. So once you see that in front of you, then it will be very easy. You can correlate to that. So do anyone have any experience for treating delirium before, or was it difficult to manage or identify the delirium state? Say yes or no. No. Okay. Okay. So I hope today, through this class, you all will get an idea about delirium, how to be diagnosed, and how to manage delirium and all. Okay. 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 So why it is important? Because it is one of the symptom that is misdiagnosed or undiagnosed. Okay. So to identify the delirium, it is very important. Okay. So as early that we diagnose the symptom as delirium, so that we can start the management and it will help the patient. So the early diagnosis is important. So when a patient is confused or when a patient is agitated and all, we should not misinterpret the symptom. So that is very important. Then identification of the causes. We have to identify the causes behind the delirium. We will see this in detail. Okay. And the prompt management is essential. And yes, this is a medical emergency. Why? Because when suppose you are seeing a patient in your ward. Okay. For few days you are seeing the patient, and on the next day when you are seeing him, he is not identifying you, or he is telling something disoriented. Okay, you cannot identify what has happened to him, so you will be in a confused stage. The patient is already disoriented, you cannot ask anything to him, what is happening to him you cannot identify. At the same time, the family members may be seeing this for the first time. Okay, so everyone will be very panic, and sometimes the patient may be very agitated. Uh, Restlessness may be there. Sometimes they may not be lying or sitting peacefully. They may be running around the house, and so everyone will be panic in a panic situation. So it's a medical emergency also. Okay, and it will increase the morbidity and mortality. Okay, and affects the quality of life. Of course, when a patient cannot think, and okay, when the orientation is being affected, it will definitely affect the quality of life of the patient as well as the family members. Okay, next. And the prevalence rate, it is mostly seen after ICU admissions and during prolonged ICU admissions, especially in this old age patients and all. Okay, 30 to 40% of elderly hospitalized patients, we see this delirium, and 20 to 20% of hospitalized adults. So the exact value you need not to remember, but its prevalence is very high in ICU patients. Okay, for example, sometimes while we are asking the history, you will get a history of ICU admission before 1 week or 2 weeks before. After that, the disorientation may be start. Okay, or during the COVID situations and all, when the old age people are restrained to their home, we could see many cases of delirium, okay, or confused state of mind. Previously, it was already termed as psychosis, but now we use the term delirium for that. Okay, so you have to uh, keep this in mind. It is very common in old age patients, ICU admission, post ICU admissions, and during ICU admissions and all. Okay, next. And the delirium is characterized by an acute change in cognition and a disturbance of consciousness, usually resulting from an underlying medical condition or from intoxication of medication or drug withdrawal. Okay, so as some of you have said, uh, it is a change in cognition. So, and disturbance of consciousness. The patient may not be oriented about the surrounding and about themselves and about their near ones and all. So their memory will be affected, their cognition will be affected, and as well as their consciousness will also be affected. They will not be aware about their surroundings. Okay, so and that can happen because of an underlying medical condition. Okay, So, most of the patients coming to us may be cancerous patients. So the tumor, the disturbance itself can cause delirium, or it can be due to an intoxication of medications, or maybe due to drug withdrawal. So you might have seen drug withdrawal or withdrawal symptoms you might have seen during your postings and during your career. Uh, did anyone see this withdrawal symptoms or delirious state in those patients? Or in casualties and all, we usually get these cases, right? Withdrawal symptoms, the patients will present with alcohol withdrawal. So that is also a delirious state. Okay. And intoxication of medication. I think you all have got class on pain management and morphine, methadone and all. So did you might have already hear about delirium. So which intoxication? It is one of the toxicity signs of what? It's very clear. I want all of you to respond, okay? Then only you can learn. Yeah, side effects of what? You have already learned about that. Yes, medicines. Some of the medicines will cause the side effects like delirium. Which medicine? Can anyone tell any example of medicines which cause delirium? Yeah, morphine. Yes. In general, we can tell as opioids, morphine, methadone, even tramadol. If it is in a toxic dose or higher dose, then it can cause delirium. So when we are prescribing opioids, we should uh, educate the caregiver to watch for the toxic signs also. Okay, next. What are the clinical features that we see, or what are the how they present to us? Okay, the prodromal symptoms include the restlessness, anxiety, sleep disturbance may be there, irritability may be there, poor concentration. Okay, so sometimes the patient may be very restless. They may not be lying down in the bed. They may be just waking up and again lying down, and they may be telling to the caregivers that I can't sleep. And mostly there may be sleep disturbance. The patient may be irritated, and some anxiety factors may be there. Okay, and poor concentration. Okay, while you are dealing the rounds or when you are seeing the patient in OP, they may be listening, but they may be answering to you, but in between, they easily get distracted. Okay, and there may be impairment of memory. Okay, can be short-term memory and disorientation of time, place, person that you already know. Okay, and misinterpretations may be there and increased or decreased psychomotor activity. Okay, that can all these next and altered sleep wake cycle. The patient may not be sleeping in the night, they may be sleeping more during the daytime, and motor abnormalities may be there, and emotional disturbance, anger, agitation, sadness. Some patients may show the hallucination, delusions, okay, cortical abnormalities, all these things. So, in total, the patient's cognition and consciousness is being affected. So, we have to, while we are assessing, we have to assess all these things. We have to keep in mind all these things. Okay. Most of the patient may be restless. Okay. We will see the types of delirium. So you should not misdiagnose or misinterpret this. Okay, so if a patient is restless, if a patient sleep-wake cycle is being altered, or if the patient is agitated, anger, the patient is showing hallucination, delusions, or some restlessness. Okay, if a patient is coming to you with, or if you are seeing a patient in home care or OP or ward or anywhere with these symptoms, you have to rule out delirium. At least this much you have to keep in mind. Okay, you should not misdiagnose or undiagnosed. Okay, now you are learning about delirium, so you have to keep this in mind. If you are seeing a patient in future with any of these symptoms, you have to rule out delirium. Okay, next. And the diagnostic criteria for delirium, mostly we use Diagnostic and Statistical Manual of Mental Disorders 5. Okay, next. That is, we are already told, that is a disturbance in attention. That is, that is a reduced ability to focus. They may not be able to focus on what they are telling or what you are asking them. Okay, they will shift their attention from one to the other, and the awareness will be also be affected. They may not be aware about the surroundings. Okay, sometimes they may be telling you they are in the home. Sometimes the patient may be admitted in the hospital. They may be what? They may not be aware about the caregivers, or they may not identify the near ones and all. And till last day, or they may identify you, but when you are going for the next day during the rounds, they may not identify you. They may identify you uh, as their daughter or son or something like that. So all these are the symptoms. And the change in cognition, there may be memory deficit, disorientation may be there, language disturbance, all these things can be there. And disturbance, it can develop very short, in a short period of time, can see in acute phase. Okay, that means sometimes today if we are seeing a patient in OP, they may be completely okay, but within few days or within few hours, this delirium can happen. Okay, and it tends to fluctuate during the course of the day. So you have to closely observe the patient. Mostly this delirium or a confused state of mind happens, or it worsens during the night time or evening hours. But all the cases you have to closely monitor, and you have to keep in mind it usually fluctuate during the course of the day. Next. And from the history we can get an evidence. Okay, like ICU admission, or from the physical examination or laboratory findings. Okay, and it can be a direct consequence of the medical condition itself, or can be intoxication of substance abuse or medication use, or more than one cause also possible. Next. Okay, coming to the clinical subtypes. Now you have seen the most of the symptoms of delirium, right? So I hope you all will be able to identify the delirium or the symptoms of delirium in future. Okay, so now coming to the subtypes, it can be hyperactive, hypoactive, and mixed. Okay. So hyperactive means there will be restlessness, agitation, hallucination, delusion. These are the patients. Okay, it's very easy to identify this patient. Okay, this type of delirium. Why? Because it is very obvious in front of your eyes. So there will be a drastic change from previous days. They will be very irritated, agitated, or disorientation may be there. So mostly comparing to hypoactive delirium, it is very easy to identify. But there is a chance for misinterpreting this diagnosis. Why? Restlessness, agitation, or saying something unusual things and all. So we may refer the patient to a psychiatric doctor or a psychologist, or hallucination and delusion may be there. So there is a chance for misdiagnosis. So you should not send them to a psychiatrist in the uh, what first sitting. You have to identify or rule out the delirium, okay, before sending or referring them, or okay. And second thing is hypoactive delirium. Hypoactive delirium, that you have to keep in mind. Why? Because it is the most undiagnosed symptom. Why? Because the patient may be very calm when you are seeing them in OP. They may be presenting us with the patient is very tired, lethargy, or like they are not answering anything. So we cannot ask them and identify their symptoms from them. So the caregivers may be telling like, okay, they are sleeping for most of the time, or they are not listening to us, or they may be tired. Okay, so when you are asking them about the symptoms and all, they may not be listening, or they may be just pinching on the chair, or sometimes uh, what they may be pinching the diaper or like that way. So you have to see, okay, you have to closely observe, is there any change in their consciousness or cognition, whether they are listening to you properly. If they are not listening to you properly, if they are not answering to you than usual days, then you have just to rule out other causes, okay, any causes like that way. So this also you have to keep in mind. Some patients will present as hyperactive, some patients will may present you with hypoactive delirium, okay, and mixed. Okay, it's very easy. There may be both the symptoms. Okay, alternative features of both agitation and lethargy. Next. So, sometimes a patient is not answering you, or they are not remembering or recollecting uh, their near ones, or sometimes they misinterpreted the things around them. So in those things, what we usually diagnose in our setting, or what we have already seen during our studies and all, most common thing we have seen is dementia. During dementia, the old age or dementia patients, in dementia patients, they may not be able to identify, or in depression stage, the patient may be very lethargic, or the patient may not be listening or doing anything. They may be very subtle. So hypoactive delirium we may misinterpret as a depression. And in this short term memory loss and misinterpretations of the things and all, if it is there, then we may misdiagnose that as dementia. And mania, if there is a hallucination, delusion, all these things, or agitation, if it is a mixed hypoactive, hyperactive delirium and all, and there is a change in the way they are talking, or all these things, what we usually interpret is any psychiatric symptoms like mania, or maybe part of old age, like that way. So we should not misinterpret or misdiagnose delirium. So we should know all these things also. Then only we can identify, right? Next. So here we will see the features of delirium, dementia and depression. In delirium, as we have already seen, it can happen in acute. That means within hours to days, the delirium can happen. Okay, dementia, it's a slow progress, and the duration may be months to years. Depression also, the duration will be in months to years. But in delirium, it can last within hours to days. You can identify easily. Okay, not easily, but it can happen in an acute manner. Okay, and course. Usually there is a fluctuating phase. That means in between. Okay, if you are assessing a person for uh, 5 days, you can see the phases of normal stage as well as the delirious stage. It can fluctuate within hours. Okay, during the daytime, the patient may be okay, but during evening hours or night hours, they may be talking some they may be having some irrelevant speech, or they may not be sleeping, they may be talking unnecessary things, or they may not be identifying the relatives and all. So it can fluctuate even within the day. Okay, but in dementia, it usually doesn't present like that. Why? Because the change is already settled, and the symptoms may be progressive. There may not be a normal phase or lucid phase in between. Okay, and depression, we all know it's a chronic thing. So all these things we have to identify early. As early we start the interventions, the course will vary. And duration, delirium, as we already said, it can happen, or it may present within hours to weeks. The dementia, the duration is usually months to years, and it's usually progressive. Okay, and consciousness. Consciousness, it is consciousness means what? They may not be aware about the time, place, and the person, and the awareness around their surroundings, environment. They may not be able to identify. That will be altered. In dementia, in the initial stages, they may be the consciousness may be clear. Okay, in depression, it is usually clear. The consciousness will not be affected. And attention, attention, it will be impaired in case of delirium. Okay, in early stages of dementia, the attention will not be affected. But in severe dementia or in late stages, the attention will be affected in dementia also. And in depression, it will be decreased. Anyway, it is mostly affected in delirium. And psychomotor changes, it may be increase or decrease. Dementia may be normal. There may not be any psychomotor changes. But in depression, we know there may be a slowing down of activities. And reversibility, it is usually reversible. That is the one thing. Okay, it is usually reversible in case of delirium. And in dementia, yes, if we can identify the dementia early, the progress we can just prolong. Okay, the impact of the dementia, and we can just uh, control, or we can start some activities, or we cannot reverse the condition, but we can reduce the progression. Okay, to an extent. And depression, it is usually reversible. Okay, so it is one of the most important thing, the reversibility. Why? Because once we identify the delirium early, we can reverse the symptom completely. Okay, so that you have to keep in mind. What is the importance of identifying this delirium? It is usually a reversible symptom. So you have to identify this delirium. So the most of the symptoms are similar, right? In delirium, dementia, depression, or in mania, and all, or in some psychiatric disorders, the patient may present like this: some agitation, hallucination, delusion, restlessness, or misinterpreting things, or not identifying the near ones. They may be very agitated, or sometimes they may be very quiet. They're like what, in depression stage or like that way. So, what I will suggest you is, when you are seeing the symptoms, you have to keep this in mind. Okay, and you have to rule out this. Okay, and one thing is, it is irreversible. So, how we can reverse this, we will see in the subsequent slides. Next. And dementia, we have already seen it's a memory impairment. Disorientation may be there, can be chronic or slow onset, and it's progressive and it's usually irreversible. Next. Depression, there may be loss of interest, sadness. The same way the patient can present in the hyperactive delirium. Okay, the disturbance of sleep, appetite, concentration, and energy will be very less, and feeling of worthlessness, hopelessness, suicidal thoughts, and all. This is seen in depression. Suicidal thoughts will be seen in depression. Okay, uh, but their consciousness may not be affected. It will be clear. Okay, you can just identify the delirium by that. Okay, the patient may not be aware, their orientation may not be affected in case of depression, but in delirium it can affect. Okay, and depression, it is usually a chronic thing, so it cannot happen in an acute manner, but in delirium it can present within a day or present within a week. Okay, next. What are the risk factors for this delirium? One of the main thing is old age. Okay, so uh, even a small change in their environment or disturbance can affect the patient in the old age. Okay, so when we are dealing the elderly patient, we have to be very cautious. And visual impairment. Sometimes the patient may be interpreting you as their near one, or as their daughter or their son or their relatives, or like that way. Why? Because they may not be seeing you properly. There may be some visual impairment, or they may be answering uh, in a wrong manner, maybe due to hearing impairment. So you have to rule out all these things. Okay, why? Is there any reason for their misinterpretation or disorientation? Okay, so alcohol abuse, any depression or something. Okay, these are the risk factors. Next. And causes of delirium. So we have seen it is not, it is reversible. Okay, so how can we reverse this condition? We have seen it may be due to a medical condition, underlying medical condition, may be due to an underlying substance abuse or intoxication or metabolic disturbance. All these can cause delirium. And in old age, even a small change can cause this delirium also. So, these causes of delirium also you have to remember all these things. Why? Because even we may think these things are very what this dehydration, infection, pain, and all. We used to treat these symptoms, but we may not think that these symptoms itself can cause another symptom like pain. Okay, or change in environment. Okay, we have seen it is mostly seen in ICU patients. 80% of ICU patients can present you with delirium. Why? Because the change in environment. In old age, when a patient is being shifted from home to a ICU setting with full of lights, beep sounds, and they may not be able to sleep during the night time, and there may be continuous monitoring of the vitals, medicines may be giving, multiple injections may be there in ICU settings. Okay, so all these things will affect their cognition as well as awareness. And the change of environment itself can cause what? Delirium. So this you should keep in mind. And another thing is, sometimes you may admit the patient for pain management. Uh, okay, in your hospital, but there is a change in environment from their how, right? So that itself can cause the pain might have reduced, but there may be some irritation, or the patient may be very irritated, or disorientation may be there. So you have to identify the cause of delirium. Only if we identify the cause, we can reverse the delirium. Okay, so the causes you have to keep in mind. Even a small change or even a small cause can cause this delirium in old age, especially. And unfamiliar excessive stimuli, for example, bed sheets or crumbs in bed. Okay, these are very silly, simple things. Okay, you may misdiagnose this, or you may not take it serious, like this bed sheets or crumbs in bed, or this change in environment or all. So you have to keep in mind, and you have to correct all these things also. So okay, and pain. Severe pain can cause delirium or uncontrolled pain. Okay, uncontrolled pain management can cause delirium. So once we correct the pain, or once we correct all these things, the symptom will reverse. Okay, so it's very important. Uh, okay, I don't know. Some of you have answered that you have not seen delirium in your setting. If you were working in palliative, definitely, I think for more than 1 year, if you were working in palliative care, then you might have misdiagnosed or undiagnosed delirium. Okay, so in future, you should not misdiagnose or undiagnose this delirium. So you have to keep this in mind. The symptoms you have seen. So now you have to know the causes of delirium. What are the things that can cause delirium in an old age patient or in an adult or in any patient? Okay. So the pain itself can cause delirium. It's very important. Some of the patient may present you with this delirium stage. They may not be telling you about the pain. Okay, the patient may not be telling you about the pain. Caregivers may not be telling you about the pain. They may be presenting you with the symptom of delirium, agitation, restlessness, and all. So you have to identify the cause, whether there is pain. For all patients, you have to ask all these things. You have to keep all these things in your mind. So it's very, very important. Okay. So next, fecal impaction. That means constipation. It's very common. Commonly, what we see is constipation can cause delirium. As I have already told, the patient may be presenting you with delirious symptoms. But when you were asking the history, you will find out that there may be history of constipation or urinary retention. You know, constipation itself can cause urinary retention. So both can also be there, but they may not tell you the symptom of constipation or urinary retention. You have to get it by asking these questions, whether there is constipation, whether there is pain, whether they have passed urine. Okay. Uh, okay. Whether it is clear, or whether there is a signs of any infection, like fever, or any redness, or any swelling. Oh, okay. Any wound that is being present. So these are the small changes. Okay. So, but this can cause this delirium, and when it is being associated with another symptom, it's very difficult to treat as well. You have to control the delirium as well as you have to manage the symptom. But once you manage the actual cause of delirium, uh, what it is usually 100% reversible, this delirium. Okay, so when you give the optimum treatment for a cause of delirium, so it is 100% reversible. So you have to ask all these things. Sometimes there may not be any infection, there may not be any constipation, pain, urinary retention, everything will be okay. But there will be very less fluid intake, or oral intake will be very less. Oh, they may be very lethargic. Okay. We may sometimes diagnose that as EOL or end of life. The patient may be diagnosed as or their CA in their advanced stage, and they may be in EOL. So we may misdiagnose this hypoactive delirium due to dehydration. So, when a patient is being presenting you with acute onset of hypoactive delirium with lethargy and all, and the oral intake is very less, fluid intake is very less, urine output is very less, then you can just uh, give the IV fluids. Okay, there is no harm. Okay, so after correcting dehydration, the patient may improve. I have seen some cases where after correcting dehydration, the delirious stage reversed. And yes, of course, we have seen we increase the morbidity as well as mortality of the patient, and it is mostly seen. So it's a warning sign also, this delirium. Okay, so why? Because if the patient starts presenting to you with this delirium, okay, there is more chance for increase the mortality, and they may be nearing their EOL. So you have to warn the caregivers also. You have to give some hint to them also. So, but initial phase, correcting the dehydration, there is no harm. So if we can increase the oral intake, it will be very good. So if it is not, then you can give some sub-Q or IV fluid also. But even after giving this IV fluid for 1 or 2 days, if the condition is not reversing, then you should not continue giving this IV fluids. That also you have to keep in mind. Why? Because in EOL patients also, end of life, in end of life also the patient may present like this. So you have to rule out the cause and you have to give the treatment, but if it is not responding, then you have to identify that also. Okay, hope it's clear. If any doubt, you can ask me. And hypoxia, this anemia, all these things you have to correct. And anxiety. Okay, sometimes the patient may be posted for a CT scan investigation or biopsy or what some other investigations for pain or surgery or chemo, radiation, all these things. So there may be some anxiety factors or any personal things or fear of dying may be there. So all these can cause or an impairment in their awareness, or cognition can also be affected. Okay, so especially in the advanced cancer and in old age and all, even a slight change of these things can cause delirium. Okay, next. And nutrition deficiency. So we know this uh, in cancer or in old age or when a patient is being affected with that disease, there will be nutrition impairment, or they may not be taking food properly. So the vitamin deficiencies can itself cause delirium, and metabolic disturbance like hypercalcemia, hyponatremia can cause delirium. And opioids, we have seen morphine, methadone, tramadol, toxicity can cause delirium. Then steroids can cause delirium. Chemotherapy, chemotherapeutic drugs can cause delirium. Antimuscarinics, brain meds, dehydration, infection, all these things. Dehydration, infection, we have already seen, and brain meds. Okay, sometimes the patient may be having a cancer. So you have the patient is presenting you with delirium. So you have to check the previous investigations, okay, whether it is due to any brain mets. So in case of brain mets, we are not, there is no point in attempting to what sometimes we of course if the patient is presenting with a delirium, you have to treat it even in brain mets, but sometimes it may not be completely reversible, or sometimes it may recur after some days. Okay, for example, what we will give if a patient is presenting you with delirium, patient with brain mets, if it is presenting with delirium, what we can give? Any suggestions? Why this brain mets cause this delirium? Okay, I will give you a hint. There will be raised intracranial pressure. Okay, so what you will give? What can you give? Apart from treatment for delirium, what can you give? You can give some steroids like dexamethasone. Okay, why? Because the raised intracranial pressure can cause delirium. While you are giving this steroids, it can reduce the peritumoral edema, it can reduce intracranial hypertension, and uh, for some weeks or some months they may get some relief from the delirious stage along with the antipsychotics and all. So but if it recurs and all, you have to give it for some days and see whether it is responding to the treatment. If it is not responding to the treatment, then you have to anyway you have to tell the caregivers we are suspecting this brain mets itself can cause delirium. Sometimes the patient may have brain mets presenting you with delirium, but uh, brain mets always doesn't cause delirium. Okay, so that also you have to keep in mind. So if a patient have this brain mets and patient is presenting you with the symptoms of delirium, you should not uh, rule out other causes. Means you should not you should rule out the other causes also. Okay, if a patient have this brain mets and presenting with you with the symptoms of delirium, okay, even though the patient have brain mets, you have to rule out the other causes of delirium also in that patient also. Okay, so there may be one or more causes. Okay, like dehydration may be there, sometimes infection may be there, sometimes pain, constipation can also happen in those cases. Okay, so you have to rule out most of these causes in almost all patients presenting with the symptoms of delirium. Okay, and sometimes the CA breast or CA lung, all these things, there is a more chance for brain mets, getting brain mets. So if the investigation they have not done prior, then you have to tell the caregivers, or you have to discuss with the family. Okay, there is a chance. Okay, we have ruled out all these causes. We have given treatment for all these causes. So there may be, okay, there may be chance for the brain mets. So that if the patient is not in UL end of life, then you can send them for CT scan after discussing with the treating doctor. Okay, there is an option for that. Okay, for okay, is it clear now? Do anyone have any doubt till now? Okay. So till now you have seen the symptoms of delirium. Okay. Will you be able to identify the symptoms of delirium? Say yes or no. Do you get any idea about the causes of delirium? What are the things you have to keep in mind, and what are the things you have to rule out? Okay, I hope all of you got an idea till now, like what is delirium, what are the symptoms of delirium, what are the other things you have to rule out, what are the most of the causes, what are the causes, main causes of delirium. All these things you have to keep in mind. Okay, next. And these are also the causes, like withdrawal of alcohol, nicotine, psychotropics, organ impairment, that is renal impairment, hepatic impairment, or respiratory failure. All these can cause. Why? We have seen. Okay, you have to keep that in mind. If the patient is having renal failure or renal impairment, hepatic impairment, and all, uh, the chance for toxicity is very high when we are starting this opioid. So usually we start in a very low dose and in less frequent dose, mostly in 6th hourly morphine. Okay, rather than 4th hourly, if the renal impairment is very high, creatinine level is very high, then we can start in 6th hourly, and we can wait for 3 to 5 to 7 days for increasing the dose. So all these things. Okay, so the or any other drug, chemotherapy drug can cause this delirium. So the toxicity is very common in case of the impairment of organs, and sleep deprivation itself can cause the delirium. Okay, uh, I know, I think most of you are below 60. So when a person is above 60, that is in the elderly stages, uh, the sleep deprivation itself can cause this delirium. And we know in young stage also, if our sleep is deprived, then we may not be completely able to interpret or do our activities in a normal way, right? We may be very tired, or so what, sleep deprivation can itself can cause delirium. So one thing you have to rule out is whether the patient is getting adequate sleep for the past days. Okay, so the sleep itself can cause, the sleep disturbance can itself can cause delirium. Okay, the surgery, trauma, these are acute things, and that can also cause delirium. So any change in their normal way of living, like surgery, trauma, or a change in environment, to a shifting to a hospital or shifting to another room. Within the home itself, they may be shifted to another room. Okay, or they may be restrained to one room for a few days because of infection, or because of some other reason, or they may not be or change in caregiver, or change in sometimes the patient may be taken care of by their children. Usually mostly be affected to one child. Now there is any shift in the caregiver or caretaker, that itself can cause delirium. Okay, these are very simple things, but you should keep this in mind. Okay, next. And steroids, drugs, steroids, opioids, anticholinergics. Okay, benzodiazepine. Sorry, there is a error in spelling. Benzodiazepine, phenothiazines, then antiviral drugs can cause delirium. Okay, next. So these are some of the tools. Mostly use the tool we have already seen, DSM criteria 5. Uh, this is another tool, that is mini mental state examination. Here we just assess the time, orientation, place orientation, uh, registration of 3 words, like, okay, I will just read out. Okay, attention and calculation, all these things, recall of words, naming of objects, repetition, comprehension, reading, writing a sentence, drawing, all these things you can check during your assessment. Okay, next. Memorial delirium assessment scale, that is another scale for assessing and the tool for assessing delirium. Next. Okay. Here also you are assessing the orientation, memory, okay, digit span, hallucination, delusion, okay, or sleep, level of consciousness, organized or disorganized thinking, okay, whether they are able to focus or sustain their attention, like that way. Next. There is a grading. I'm not going to in detail about the assessment of the tools. Uh, you have to, but you have to what? You might already know how to check the level of consciousness of a patient. Okay, it's very common in our day-to-day practice. We should ask them. Okay, simple thing is we can ask them. Okay, their name we can ask. Okay, their near one's name we can ask. The caregivers' names we can ask. Where are they now? What's the time now? Okay, we can ask their date of birth. We can ask uh, uh, about the medicines they are having now. Okay, or they may not be able to recollect all these things, or we can give some names. We can ask them to name some objects, or we can what we can ask them to repeat the names in sequence, object names in sequence, or repetition of numbers, or recollecting the numbers, or like that way. Okay, short term or long term memory loss, all these things we can identify any memory deficit or any hallucination, delusion, and all. Also, you have to identify if it is there. Okay, from their speech itself, we can identify. Okay, so in hypoactive delirium, they may be very they may not be answering you. They may not be listening to you. They may be smiling. Okay, it is mostly misdiagnosed, this hypoactive delirium. So if there is any change in cognition and awareness and response of a patient from previous days, you have to closely monitor them throughout the day. Okay, coming to the management. Uh, yes, we have seen it is reversible. So we have to identify the cause of delirium. Okay, once we identify the cause of delirium, we have to correct the correctables. Okay, the pain you can correct by giving adequate medicines. The dehydration you can correct. Infections you can correct. Hypoxia you can correct. Constipation or fecal impaction or urinary retention you can correct. How you can correct the change in environment? You can just make it familiar for the patient, or if the patient can be sent back to the home early, you can do that. Okay, these are the and electrolyte imbalance. Sometimes the patient may be very drowsy, in hyponatremia and all. It's very common. So any electrolyte imbalance you have to rule out, and you can correct that. Okay, correct the correctable, non-drug treatment and drug treatment. Next. So these are the things I have already told. And if the patient is in opioid, you have to, how you will rule out the toxicity. You have to identify the other signs of other toxic signs. What are the toxic signs of morphine? Other than delirium, what are the other toxic signs? How you will rule out it is not due to opioid toxicity. Patient may be on opioids, so you have to rule out the opioid toxicity when a patient is in delirium. How? Insomnia is not a toxic sign. Anyone? there are side effects of opioids as well as toxic effects of toxicity signs of opioids. Okay, so what are the toxicity signs of opioids? Okay, everyone should go to. Okay, after this class, all of you have to read about what side effects and toxic signs of opioids. Okay, and you have to rule out the toxicity due to opioid. Okay, when a patient on opioid presenting you with the delirious symptoms, you have to rule out the toxicity. You have to check the respiratory rate. You have to see the pupil. You have to see whether there is myoclonus for the patient. Okay, okay. All these things you have to rule out. Next, if there is hypoxia, if there may be desaturation, you have to correct it. Okay, so infection, you can send them for any blood investigations if there is a fever or a infected wound or that or fungating wound with foul smelling. So you have to do the wound management in those cases. If there is infection, you have to treat that. Brain tumors, if it is there, you can treat by giving steroids and along with the antipsychotics. So sometimes a decrease in peritumoral edema, intracranial hypertension, if it is being reduced, there may be some uh, uh, what reversibility in case of delirium. And alcohol withdrawal, if it is there, you have to identify. And nicotine replacement, if there is smoking withdrawal, sometimes we may have to give the patient this alcohol or this nicotine. Why? Because uh, the patient may be in EOL, and by completely withdrawing them from these things, we are not getting anything uh, beneficial for the patient. So in a very small amount, if they are happy with that, then we may sometimes, okay, we can advise them. If there is no withdrawal symptoms and all, okay, then it's okay. But in case of withdrawal symptoms, we have to what uh, in each case it differs. So you have to keep this in mind. Then dehydration also you have to correct. Next. And pain, you have to manage hypoxia, electrolyte imbalance, nutrition deficiency, and all these things you have to correct. Next. Coming to non-drug management. Okay. Along with the drug management, along with the pharmaceutical management, you have to keep all these things in mind. Why? Because the patient, family, and all of them will be very anxious, and all of them will be in a panic situation. So they may be very worried also seeing this irritability of the patient, and sometimes the patient may not be identifying the relatives, their close ones, their near ones. So it is usually very difficult for them to cope up with the situation. Okay, they may not be even identifying them. So uh, or they may be shouting at them. So it is difficult for the family also to handle the patient and the situation. So uh, sometimes when you are going to see the patient, they may be shouting at you. Okay, they may be calling something to your face, or they may be, sometimes there is a chance for even spitting or throwing something, or they may be telling, I will kill you, or you are doing something harm, or like that way they may be telling. So you should identify this delirium, and you should stay calm, and you should treat the patient with same respect. Okay. uh, okay. And Another thing is you should discuss this at the family members, and you should tell them this is not madness. Okay. Most of the what caregivers may misdiagnose or misinterpret that as madness. Oh, but suddenly this has happened to them, like that way they may be telling you and worrying. So you have to tell them this is delirious stage, this is not madness, or this is not something related to psychiatric uh, diagnosis. It is not like that. If we correct the causes, mostly it is reversible. You have to reassure them. You have to sit with the family and you should reassure them. Okay. And you should discuss with the family what can be done, what you can do to help them, and keep calm and avoid uh, any. Okay, you have to just sit with the family members. You may not be able to tell everything to the patient. They may not be in a state to understand everything that you are telling. So you have to sit with the family members separately, and you have to uh, ask what the situation they are going on. Okay, what how they are coping up, or what are the difficulties they are facing. So you have to explain them the procedure, what we are going to do, and what you are suspecting, everything, and limiting the number of staff carrying the patient. Okay, so you can increase the familiar. You can, if it is possible. Okay, the one or two staff can take care of them. Okay, so that the patient may be very familiar to the faces. Okay. Otherwise, the changing staff in all shifts and all, and they may be in a very confused stage. Okay. So all these things you can keep in mind, and the change in caregiver also you can avoid. So if one family member or one close or near ones who is very what close to the patient, if they can be with the patient, then it will be very good. And you can increase the visit of the family members also. You should not restrain them from seeing or their friends and relatives. You can do some adjustments for making the visits possible. Okay, next. Even if it is in the hospital, and we have to reorient the patient. So if the patient is not identifying the caregivers, or if they are not identifying the treating doctor or treating staff, anyone, you have to reorient them. How? You have to tell them, no, I am not your relative. I am okay. I am. My name is this. I am your treating doctor. Like that way, you have to introduce yourself. Sometimes you have to tell multiple times, and you have to tell this is your son or daughter, or whoever is standing nearby. You have to reorient them, or sometimes you may have to tell multiple times, and you can just, if you are asking the time and if they are telling it wrong, then you can just show them. Okay, you can open the windows and all, and you can show them this is the time, or you can tell them the exact time. Okay, and you can place a clock and which is in front of their bed. Okay, so so that we can ask the caregivers also to uh, ask them questions like what's the time, what's the date, what's the month now, what's their name, or they can show some old pictures like their family photos, or their, they can make some arrangements for visiting friends or calling friends, video call. If the children are abroad, you can make some video call possible. And so all these things to reorient the patient, the things to reorient, or if the patient is in a ward, so you can shift them to a open air area, like the rooms with very good ventilation and windows and all. If it is there, it will be very good. Okay, next. And quiet room and low voltage light is mostly affected in ICU settings and all. They may be able to sleep peacefully. And during the night time, you can switch off the light. Okay, and the disturbance around, if there is any disturbance, you can avoid that. And also, yes, you should not restrain the patient physically, and you should mobilize the patient also. You should not restrain them to a bed and to a room. Okay, you can make them go out, in an open air. If they can be shifted to an open air setting for at least 1 hour in a day, it will be very good. And mostly the restraining them to the bed. You have seen the first picture, you might have remember the first picture, no? So, and restraining them itself can cause or increase delirious stage. Okay, so keep this in mind. Uh, we are uh, we are not what uh, preferring them to restrain physically. Okay, next. And the presence of family members or close friends around them, it will help them. And also patient should be allowed to walk. Okay, but somebody should accompany. If the patient can walk, you should take them to outside. And okay, and reorientation technique like putting calendar, family photos, log, etc. Environment should be very calm, stable, and well lighted. And sensory deficits, if it is there, like hearing impairment or visual impairment, then you have to correct it with hearing aid and eyeglasses. Next, coming to the drug treatment. Okay, these are the correctables. Okay, so you have to identify the cause, you have to identify the cause, and after that you have to correct the correctables. Then the non-drug treatment also, it is very important. And coming to the drug treatment, so once you identify the delirium, along with the drug, non-drug treatment and correcting the correctables, you have to start an antipsychotic drug. Okay, so haloperidol. Mostly, we start haloperidol for acute onset of delirium. Okay, we usually give it for 5 days or less than 5 days, and see, with 1.5 milligram of oral tablet, we can start a night dose, usually 1.5 to 3 milligram orally, 8 hourly we can give. You can start with an once daily dose, and you can see if it is helping the patient. And rescue doses also you can give, but you have to keep in mind not more than 20 milligram. In 24 hours, the maximum dose is 20 milligram. So the patient is not able to take it orally, even subcutaneously we can give haloperidol. And IV. If IV access is difficult, then we know to have multiple puncture or multiple pricks for getting an IV line. You can give it by subcu also. Okay, next. Atypical antipsychotics like quetiapine, olanzapine, risperidone. Okay, the doses, you can start it with 12.5 to 25 milligram. Okay, OD and BAD doses you can give, and olanzapine and risperidone can also be given. Quetiapine and all, in uh, if the delirium is not settling down with haloperidol and all, and if the patient is having sleep disturbance and all, this quetiapine and all will help for getting sedation as well as for correcting the delirium. Okay, next. And benzodiazepines, usually we start with antipsychotics, but after even after this starting antipsychotics, or if the patient is having hyperactive delirium and all, sometimes we may have to add benzodiazepine also, like lorazepam, midazolam. Midazolam, it is a very short acting benzodiazepine. To induce the sleep or sedation, we can give this midazolam. Or if the patient is continuously restless or agitated, hyperactive and all, we sometimes we may have to give it continuously through IV or sub-Q line. So you can just give it by bolus dose like 1 milligram, and see whether they are settling down. If they are not settling, then you can give rescue doses in 1 milligram dose or 2 milligram dose. Okay, so if they are not settling down, or sometimes depending upon the situation, we may have to give continuous subcutaneous or IV infusion also. Okay, the dose you can start it as 1 milligram per hour, and then you can gradually increase or reduce or stop. Okay, and lorazepam, it's a oral medication, or sublingually also you can give, and sub-Q, IV, sublingual, peroral, all these routes is possible in lorazepam. Usually we can start with 0.5 to 1 to 2 milligram. Okay. Usually the patients used to settling down within 2 milligram dose. Okay. These are the medications. So whenever a patient is being diagnosed with the delirium, you have to rule out delirium, and you have to treat the causes. Okay. Once you treat the causes itself, the delirium will reverse. Sometimes, okay, one thing is oral thrush. Okay, you have to see the oral cavity of the patient also. This oral thrush itself can cause a delirium. So these are the some of the things you have to correct the correctables. Then non-drug treatment also you have to keep in mind. Then coming to drug treatment, along with the non-drug treatment and the other thing, correcting the correctables, you have to start the antipsychotics also for some days, and you have to observe whether they are responding to the treatment, and then you can gradually reduce and stop these antipsychotics. And you have to warn the family members regarding morbidity, mortality, prognosis and all, depending upon the situation. Okay, thank you.
Thank you, Dr. Greeshma, for the wonderful presentation. Anybody have any doubts? Anybody? It's clear. What about others? Sunita said it's clear, no doubts. So, okay, Shani ma'am also said it's clear. So I hope your presentation is clear to everyone. So this is one of the, as I mentioned earlier, this is one of the so commonest symptom, which is mostly underdiagnosed. So you have to, if a patient, the patient is coming with a confusional stage, it's our duty to identify the cause. So we have to treat the underlying cause, because most of the patients usually can develop delirium in the inpatient units. So we all nurses, we used to do the restrain their limbs. Usually, if they have if they developed a confusional stage, we used to do restrain their limbs, so that they also, if you restrain their limbs also, the patients can produce restlessness. So instead of restrain their limbs, or what you can do is you can to identify the cause, especially. So you have learned about many causes, the contributive factors, especially constipation, urinary retention, electrolyte changes. These all are the common causes the patients can develop delirium. So this we can easily that identify. Always that treat the underlying cause, as ma'am said earlier, and then you can think about the non-pharmacological management, and then if the non-pharmacological management is not helpful, then you can think about pharmacological management. So always you have to give a proper reassurance to the family members, because if someone's developed this kind of confusional stage, restlessness, these kind of, they will tell something during the confusional stage, so they might be thinking like, oh, he's a madness. So these kind of things, clarification is very, very important. You have to clarify, you have to give an enough the instruction to the caregivers and be with the patients, and respect. You have to care with respect. Don't give any jokes. Don't make any jokes in front of the patients if they are in the confusional stage. So after they get back to that confusional stage, they might be recollect all those things. So you have to be keep it in mind all the time when you take care of these kind of patients. So I think no more questions. Thank you, Dr. Greeshma, for the wonderful elaborate session. Thank you others for your participation and contribution. Thank you.
Thank you.
Thank you, Doctor, for the wonderful presentation. Thank you, Shilpa ma'am, for the wonderful presentation. Thank you all for joining. Thank you.